Greetings from the World Health Organization. My name is Chandramouli, and I lead the work on adolescent sexual and reproductive health and rights in WHO's Department of Sexual and Reproductive Health and Research. Welcome to this presentation on progress in the 25 years since the International Conference on Population and Development and prospects for the next 25 years. This is the second of a series of 4 papers, and this paper is titled The Political, Research, Programmatic and Social Responses to Adolescent Sexual and Reproductive Health and Rights in the 25 years since the International Conference on Population and Development. And as you can see from this slide, we brought together a huge writing group to develop this paper. This paper set out to answer 2 questions listed on this slide. 1, how have epidemiologic trends and political, research, programmatic and social responses to ASRHR evolved in the 25 years since the ICPD? And we examined the 6 areas listed on this slide. I'm not going to read them out. We will go through them one by one. And the second question is, what contribution did the ICPD make to progress in each of these 6 areas? The first area that I'd like to address is adolescent pregnancy and childbearing. And we've used the Mary Stopes International slogan, children by choice and not by chance. And this is one of a series of wonderful images that our long-standing collaborator Graham Ogilvie from Edinburgh in Scotland has produced. This slide addresses levels and trends of adolescent pregnancy and childbearing. And this slide makes 5 points. 1 is that the global adolescent birth rate has declined over the last 25 years, as you can see from this slide. The second point is that all regions of the world have shown declines, but there are enormous differences between the regions of the world, between countries in each region, and within countries. However, sadly, in some countries, because of a combination of factors that we can go into later, the rate has actually increased rather than decreased. The third point is we generally talk about pregnancy and childbearing in the 15 to 19 age group, but estimates suggest that births in 10 to 14-year-olds are seen in some countries and are not negligible. The fourth point is that although the adolescent birth rate is declining, the population of adolescent girls continues to increase globally and especially in some parts of the world. This means that the absolute number of adolescent births is actually increasing, especially in sub-Saharan Africa. And my fifth and last point is that many studies show that adolescents have higher unmet needs for contraception than other groups, than older women and men. This means that there's a higher unintended pregnancy rate, and sadly, many of these unintended pregnancies end in abortion, often unsafe and illegal. Let me now go to global and regional responses to adolescent pregnancy and childbearing. This slide contains 4 points. 1, adolescent pregnancy prevention was on the agenda of the ICPD. It was actually an important part of that agenda. However, it was missing from the Millennium Development Goals agenda till 2007, when a subgroup goal on reproductive health was added to MDG 5, the Millennium Development Goal 5, as you can see in this slide. Despite that, there wasn't much attention being paid for the first 10 years of the Millennium Development Goals because the world was focused on other issues such as um, childhood mortality reduction and maternal mortality reduction. But since 2010, a number of global initiatives have advocated for and supported action on adolescent pregnancy and childbearing prevention. And one important contributing factor is the recognition, the growing recognition that adolescent pregnancy prevention can actually contribute to the reduction in neonatal childhood and maternal mortality. The third point is that despite this, much of the focus has been on pregnancy prevention. Care and support for pregnant adolescents has received much less attention. And this is particularly important because recent studies suggest that adolescents are much more likely than adult women to experience abuse and mistreatment during childbirth at the hands of health workers. The fourth and last point in this slide is that the evidence base on preventing and responding to adolescent pregnancy and childbearing has grown. And this growth in the evidence base has contributed to the development of norms and standards. However, there are still gaps that need to be addressed. So where are we today with adolescent pregnancy and childbearing? With solid positioning on global, regional and national agendas, a growing body of evidence feeding into norms, standards and guidelines, and an increasing number of countries stepping up action, the stage is set for continued progress. So the perspective is positive. What are the factors that have helped this? In this slide you see two factors. One is we have evidence that a combination of feasible and effective interventions when applied at scale can reduce unintended pregnancy and early childbearing. Secondly, while efforts to address pregnancy and childbearing in adolescents through the health system and using a public health lens have played an important role, so have advances in girls' education and complementary efforts to reduce the number of girls getting married below the age of 18. So these efforts have kind of worked in synergy. This slide lists 4 hindering factors, and they are still there all over the world, in high, middle and low income countries. Adolescent sexuality is not acknowledged. Adolescents are not acknowledged as sexual beings. Despite progress, there are both demand and supply side limitations on the legal and social and service delivery fronts. There's also, weak delivery systems, not just for adolescents, but for children and adults as well. But particularly, there are barriers for adolescents, special barriers for adolescents. Intersectoral coordination, which is so important in so many areas of public health and development, are weak, and data gaps remain. Although we must say that we have much more data than we have had. There are a number of challenges listed on this slide, and I'm not going to go over them in detail. Suffice to say that national policies and strategies are there in many places, and now the challenge is the operational one. To focus on at the subnational level, develop context-specific interventions, engage governments to take the lead, work with the private sector, and as you move forward, to move away from a project to a program focus and to move from a short-term to a long-term focus. You'll see the full set of points in the PowerPoints that are provided to you. Thank you. This paper addresses 6 health issues, and on each of these health issues we have provided a country example. A country example to showcase what is possible. And in relation to adolescent pregnancy and childbearing, we're very pleased to share the example of Uruguay. The adolescent birth rate in Uruguay declined from 72 births per 1,000 adolescents in 2014-15 to 36 per 1,000 adolescents today. This was 2019. So this is really a halving. And this progress has been achieved in a short time frame through progressive laws and policies, a strong government-led multi-sectoral response, not piecemeal short-term projects, but also active civil society engagement in monitoring what has happened. So this has been a combined all of society approach, all of sectors approach. Please have a look at the case study in the supplement in more detail. The second topic, the second of 6 topics, is HIV in adolescents and young people. And the image that is here is inspired by the work of Zwandiri, an organization in Zimbabwe, about which I'll speak in a few minutes. And what it showed through its work, and it shows through its work, is peer counseling can improve adolescent HIV care and support. What the Zwandiri has shown is engaging young people living with HIV to reach out to and draw in their peers for testing and treatment and sustained care has been shown to be effective, is effective. Let me now move on to the levels and trends in HIV. Over the last 25 years, the estimated numbers of new HIV infections have fallen, as shown in this slide. But the number of adolescents living with HIV has risen for 2 reasons. One is because there are more children who've been infected with HIV perinatally surviving into adolescence, and of course, those adolescents who are on antiretroviral treatment are surviving rather than dying. The next 2 points point to the fact that adolescent girls are much more affected. The burden in adolescent girls is much more than in boys, both in terms of girls living with HIV and in those who are getting infected. And data on levels and trends of young people of key populations are limited, although data suggests that levels are high and increasing. And this is a concern, while we are talking about infections in generalized epidemics. There are pockets of infection in many parts of the world where not much data is available. Let me now move on to global and regional responses. So HIV in adolescents and young people has been on the agenda for a very long time. The Global Program on AIDS, UNAIDS have worked with a number of partners to contribute to this. The subject was on the agenda for the UN General Assembly Special Session in 2002. It was centrally placed in the MDG agenda. UNAIDS was established in 1996 and contributed both to advocacy work and also to putting together interagency evidence-based briefs. Since then, there have been a number of adolescent-specific and adolescent-relevant guidelines. Adolescents are being included in research studies, but adolescent-specific research has been limited, although this is beginning to change. And an important development in 2002 was the establishment of the Global Fund for AIDS, Tuberculosis and Malaria. This has meant that there has been serious money invested in responses, prevention and care in relation to HIV in general, but also in relation to adolescents. Moving from global and regional responses to national and subnational ones in this crowded slide, In the 1980s and 90s, HIV prevention efforts aimed primarily to improve knowledge and understanding and to promote safe sex among all young people. So it was a kind of a blanket approach. In the early 2000s, recognition grew of the need to address environmental drivers of HIV. It was not just about telling them about HIV and telling them to protect themselves. It was also addressing the factors that contributed to infection, that prevented them from taking charge of their lives. This was particularly true for key populations, for marginalized groups of adolescents. While the best evaluated successes are the application of biomedical approaches such as antiretroviral therapy, voluntary medical male circumcision, and pre and post-exposure prophylaxis, there's recognition that we cannot entirely rely on that, and you need combination prevention approaches which combine biomedical approaches with addressing social and structural drivers of behavior. And a very good example of that is the US government-supported DREAMS initiative in several countries of Southern and Eastern Africa. DREAMS means determined, resilient, empowered, AIDS-free, mentored, and safe girls. That's the dream of the DREAMS initiative. Moving to care, the large number of adolescents living with HIV is increasing pressure to expand coverage and quality for the entire HIV treatment cascade. And gradually, adolescent uptake and support to adolescents is increasing. There was a huge problem with treatment failure 5 years ago, 10 years ago, and that clearly is being addressed. Both treatment and prevention have been impeded by legal and policy constraints such as mandatory reporting requirements and age of consent policies, and that is being addressed, and increasingly greater attention is being paid to key populations. And one of the big areas is attention to meaningful involvement of young people. This has clearly become a central focus of the HIV response, and this is required now in funding proposals and in research projects. So where are we with HIV in adolescents and young people now in 2021, 2020? The energy and determination to end the HIV epidemic continue. Increasingly, they benefit from improved methods of understanding the epidemic among adolescents. So clearly, it has taken time, but there's a sense that that there's both the commitment to do something and the knowledge to do it. So what has helped? Increases in epidemiologic data, programmatic data, clear agreement that it's not going to be piecemeal approaches, that you need combination prevention, and that adolescents need to be addressed with specific attention at all steps of the prevention and treatment cascade. If you want further information on that, you can turn to the UNAIDS documents included in the list of references. What are the hindering factors? Reluctance to acknowledge that adolescents are sexual beings, inadequate attention to the vulnerability of girls and young women, although this is changing, and the DREAMS project is an important example of this. Competition for resources between HIV treatment and prevention, and silos between HIV and other areas of sexual and reproductive health is a big problem. And then despite a growing openness, the prevailing message is that sex is dangerous and that children and adolescents should not have it and should be protected from it. And this, of course, inhibits open and progressive approaches to prevention and care. The prospects for the future are positive. As I said earlier, energy and determination to end the epidemic continue. There is increasing understanding, and there is growing recognition that that if we are going to address this, we have to address the social and economic context of adolescents' lives. I close the section on HIV with this inspiring case example from Zimbabwe. Zimbabwe overall has made enormous progress in scaling up efforts to prevent HIV and provide care and support to the population as a whole. On this slide, you'll see that HIV prevalence has declined by over 25% in the 15 to 49 years age group, and that Zimbabwe is on track to achieve the 90-90-90 fast-track global targets listed on this slide. Knowing diagnosis, on sustained antiviral treatment, and on viral suppression. However, progress in these cascades are lower for adolescents than they are for adults. Examples like Zwandiri inspire us to believe that further progress can be made. So this was an initiative to, as I said earlier, to engage young people to work with adult service providers in addressing the problem of lack of knowledge of HIV infection, lack of access to and use of antiretroviral treatment, and poor adherence. So this initiative, which included a theory-grounded, multi-component, differentiated service model for children, adolescents, and young people living with HIV, in which peer-led community services were fully integrated into facility-led treatment and care, led to improved uptake of testing, retention and care, adherence, and viral suppression, and also to improve psychological well-being. And this has been demonstrated not just with monitoring data, but with randomized controlled trials. And Zwandiri's success is because of strong government leadership, standardizing and integrating the program into the national service delivery mechanism. It moved from a project in Harare to a nationwide response and is being emulated by a number of other countries. There was meaningful engagement of young people at all levels, and then program data and research evidence has helped to shape and reshape the Zwandiri response. The third of the 6 areas that this paper addresses is child marriage. We've used the slogan in this image from Girls Not Brides, that girls should be girls, not brides. And here is another wonderful image by our artist, Graham Ogilvy. Levels and trends in child marriage. In 25 years, the proportion of girls married before 18 has dropped from 1 in 4 to 1 in 5. This is an enormous achievement. South Asia and the Middle East and North Africa have seen the largest declines. Moving to global and regional responses, child marriage was in the ICPD agenda. It was not in the MDG agenda. It was pushed onto the global agenda by a movement led by Girls Not Brides, a global partnership of organizations working to end child marriage. This happened in the last 5 years of the Millennium Development Goals era, 2010 to 2015. It is on the SDG agenda. In fact, it's high on the SDG agenda. It's also on global and regional political agendas, for example, in the agenda of the Interparliamentary Union. National and subnational responses now. So non-government organization-led efforts began in the 80s and 2000s. In the 2010s, they graduated from public messaging about the dangers of child marriage, telling communities that child marriage is bad, to understanding and addressing its drivers, including its structural drivers. Today, laws banning child marriage and national strategies to end child marriage are in place in a growing number of countries. These are based on evidence. In large part, the UN program on child marriage, which is co-sponsored and executed by UNICEF and UNFPA, and a number of other players provide funding and implementation support. There's also growing attention to the needs of child brides including those who are divorced, abandoned, and widowed. So while the focus continues to be on preventing child marriage, there's a growing focus on responding to the many girls who continue to be married and face the negative health and social consequences of this harmful practice. Once a taboo topic with little political or public recognition, ending child marriage is now becoming a social movement. And again, Girls Not Brides has actually led this. Many players are involved, but this Girls Not Brides provide a focus to the discussion, a kind of tip of the arrow, if you like. So what were the factors that helped this? Clear interventions for investments, so donors knew what they could fund, governments knew what they could pay for. Clear recognition that investing in girls is key to achieving a whole range of health and social goals. Now, a good indicator in the Sustainable Development Goals and an increasingly growing body of data. What are the factors that hinder progress in child marriage? Gender inequality and control and exploitation of female sexuality is high on the list. Persistent poverty, because child marriage then is a response to difficult circumstances. Continued social acceptance of child marriage, and humanitarian crisis, as we have seen with the war and the civil war in Syria, with the troubles in Afghanistan and Pakistan. When you have civil strife or when you have war, it creates, it adds to the underlying drivers of child marriage with insecurity, with poverty, and with increased chances of violence for girls. And so child marriage is seen as a protective mechanism, a safety valve at that time. The limitations in data, lack of resources, weak implementation capacity at the subnational level, particularly intersectoral coordination and action, is a big challenge and needs to be addressed. Ethiopia, a multifaceted program to address the multidimensional drivers of child marriage, led to substantial reductions in the levels of child marriage in that country. As I said earlier, we have examples of outstanding initiatives from around the world. We've so far presented examples from Uruguay and Zimbabwe, and now we go to Ethiopia. Between 2006 and 2015, the prevalence of child marriage in Ethiopia declined sharply, as you've seen in this slide. This is led by progress in 4 regions. Ethiopia's progress is one of the strongest among countries in Eastern and Southern Africa. Must add that in Ethiopia, like in many other countries, there's huge variation within the country. The activities listed in this slide contributed to this large-scale decline. The formulation of laws, universal primary school education, girl-centered projects and programs implemented by NGOs, civil society, and government, outreach to community leaders and families, and especially to influential males. So a whole battery of activities contributed to this. And today, Ethiopia has a national program to end child marriage and FGM by 2025. So it's a broader program on to address harmful practices. This is grounded in the country's constitution and in its strong legal framework to protect women and girls. The 4th area that we address in this paper is violence against girls and young women. And here is another wonderful cartoon by Graham Ogilvy. Health workers often not knowing how best to respond, and trained and mature and experienced health workers able to guide and mentor junior professionals in providing both the medical care that is needed and drawing in the legal and social support required. This slide speaks to levels and trends in violence against adolescent girls and young women. A word of background, boys and girls experience abuse, example, emotional abuse, neglect, corporal punishment and bullying. So, both boys and girls experience this. But girls are disproportionately affected by gender-based violence. It doesn't mean that boys are not affected, but the level of the burden in girls is much higher. And then an important issue is that violence against women and violence against children intersect during adolescence, because as individuals move in the pathway from childhood towards adulthood, they are in this halfway period where these two different forms of violence intersect and actually make it worse. So what are the estimates? 120 million girls below 20 worldwide are estimated to have experienced forced sex in 2014. The prevalence of sexual abuse in girls age 0 to 17 ranges from 9 to 38, with the majority of the 9 countries surveyed and included in this survey having a prevalence of more than 25. Globally, 1 in 3 girls aged 15 to 19 have experienced physical and or sexual violence by an intimate partner. And this can occur in marriage or in a dating relationship outside marriage, and rates range from 16% in high-income countries to the late 30s or the 40s in low and middle-income countries. The rates in South Asia are among the highest in the world, 43%. Unlike in other areas, trend data is not available, but will become available in the years ahead. Let me now move on to global and regional responses. So preventing violence against girls and women was part of the ICPD agenda. And importantly, this year, as we commemorate the 25th anniversary of the International Conference on Women, it was in the agenda in that conference, in the Beijing conference. It's an integral part of the SDG agenda. Considerable progress has been made in building the epidemiologic base for action, as I described in the previous slide. Data on the prevalence of violence in girls aged 15 to 19 is now available for over 150 countries. There's much more evidence too on the drivers of violence, how to prevent it from occurring and how to respond to it when it occurs. This, as in other areas that I've discussed, has fed into norms, standards, and guidelines. It's also fed into a World Health Assembly plan of action to address violence against women and girls and against children, passed and endorsed by the WHO's Assembly in 2014. There's limited domestic funding for work in this area. External funding is limited too, although investments are being made in a limited number of countries by a limited number of funders. Moving to national and subnational responses, many countries have adopted laws addressing different forms of violence against, for example, rape, child sex abuse, domestic violence, intimate partner violence. However, implementation of these laws is hampered by weak capacity and because stigma hinders those experiencing violence from coming forward. This is a big limitation. Many countries are developing national guidelines and strategies and have drawn upon WHO's guidelines to do this. Countries have experimented with different models to provide care to those who have experienced GBV. However, large-scale implementation is still limited and under-resourced, as I said in the previous slide. There's heightened public awareness because of high-profile cases which have led to public protests in many countries around the world, in India, in South Africa, in Brazil, in France, all over the world. On the other hand, data from national surveys suggests that a high proportion of boys and girls condone violence in different situations. So on the other hand, there are clearly different threads to this discussion. On the one hand, there are public protests. On the other hand, people quietly think that this is the norm and accept that this is the norm. Clearly, much more work is needed. So, at the end of the 25 years of the ICPD, if in a one sentence statement of the state of the field in this area, dedicated resources, political commitment, and coordinated effort are needed to scale up promising programs, to use the data that is available on the scope of the problem and in the evidence on its on effective approaches. So what has helped? Grassroots autonomous feminist movements have been instrumental in driving change in laws and policies. These have been the key. Women-led movements, feminist movements. The availability of data has helped to raise visibility. Evidence on effective interventions and on their cost effectiveness and on the cost of not investing has had a strong influence. What are the factors that have hindered progress? Conservative political environments, lack of governmental support, political support to speak out against violence, limited investment, small levels of investment, and then what has happened also is with the enormous changes that are taking place, changes in economic opportunities in the use of digital technologies and instability due to migration or crises, pose risks of exacerbating violence and developing new forms of violence. The COVID-19 crisis has hugely raised attention to this area and the need for action in this area, and we will deal with this in modules 3 and 4. We have featured Kenya as an example of a country which has taken some tangible steps in moving forward in this area. Though, as we have stressed, there are no examples, not even in Kenya, of large-scale countrywide implementation with results in terms of reduction in violence at the national level or even at the subnational level. So Kenya has taken major strides to address gender-based violence, including sexual violence, through one, enabling, setting in place an enabling legislative and policy framework, providing GBV services free of charge using an integrated approach in 500 health facilities and 5 one-stop recovery centers located in tertiary facilities. So clearly, both the enabling framework and services have been put in place in a public communication program, and this is good. This is the move in the right direction, and other countries need to do this and build on the experiences from Kenya that everybody is watching with a lot of care and interest. The fifth area is female genital mutilation, and the slogan we've used is of the movement. It's time to end FGM. And this image celebrates the work done in a number of countries, for example, in Senegal and in Burkina Faso. This slide addresses the levels and trends in FGM. An estimated 200 million women and girls who are alive today have undergone FGM. The prevalence of FGM has decreased from 49% in 1991 to 31% in 2019 in the 24 most affected countries. But progress, as in many other areas, is uneven. The absolute number of women and girls at risk is greater because of increases in the adolescent segment of the population. We talked about that in relation to other health issues as well. FGM, in terms of global and regional responses, FGM was part of the ICPD. It was not part of the MDGs. And here are some important milestones. 2007, a joint statement with 3 UN agencies. 2008, an updated statement. In 2007, a UNICEF UNFPA joint program, which has now been modeled for a program on child marriage. In 2012, a UN General Assembly resolution. In 2016, it became part of the SDGs. So standardized measures have facilitated consistent and comparable measurement. Topic-specific modules have been introduced in the DHS, the Demographic and Health Surveys, and MIX, the Multiple Indicator Cluster Surveys, and they are in use in 30 countries. Research evidence is being synthesized and has contributed to normative guidance, and WHO has developed guidance and tools to respond to women and girls who have experienced FGM, a niche area given our mandate in WHO with the health sector response. Moving to national and subnational responses, nearly all countries in which FGM is widely practiced have laws in place that ban the practice. 13 countries have developed human rights-based action plans which are being implemented through coordinated efforts across sectors. Initially, efforts were limited to awareness raising by civil society bodies. Increasingly, different sectors and governments are working with community organizations in a complementary manner. The engagement of the health sector to improve management of health complications and prevent the practice within the health sector and also in the community is a critical addition to this multi-sectoral response. And there is growing funding for this work. You will recall that there's a parallel to the work on child marriage. What you started off with information raising and awareness raising, and increasingly the work has become more sophisticated, and it has also started looking at the needs of child brides, and here in this case needs of women who have and girls who have experienced FGM. So a statement at the end of the ICPD, 25 years after the ICPD, is that the international consensus for zero tolerance for FGM must be leveraged more widely for stronger programs. Some work is happening, but much more needs to be done. So what has helped progress in this area? Single intervention approaches which were in place, awareness raising, have given way to complementary multi-component approaches implemented by different sectors to address the drivers of FGM and to respond to survivors. The strong global consensus is being leveraged in a growing number of countries to stimulate and strengthen action. Hindering factors, which you will recognize from the other issues, is deep-seated social norms, embedded in cultural traditions about the status of women and girls, and the control of sexuality, lack of evaluation data on whether and how programs work, limited scale-up and replication of promising approaches, inadequate leadership from women and from workers on the front line, and really a lack of accountability of decision makers in this area, with some notable exceptions. We're very pleased to celebrate the work of Burkina Faso in relation to FGM. Large-scale declines in FGM resulting from community education, pressure to change from influential leaders, accountability encouraged by community commitments and nudged by legal sanction, and sensitive care for survivors. So Burkina Faso has achieved important results as shown in green on this slide. And this is very impressive. And this has been a work over a long time, from over 30 years, as listed in this slide. A national committee, national plan of action developed in 1990, a law passed in 1996. The law has been enforced incrementally and progressively, and what is really interesting and innovative is a helpline and a mobile court to ensure that judicial hearings take place near communities and that decisions are made quickly and on the spot in a visible manner. Youth brigades have been employed to raise community awareness, especially in areas bordering Mali. FGM prevention has been included in schools and in non-formal education. Partnerships between government departments, traditional leaders, religious leaders, journalists, associations of women and young people have been forged. And this really is very good, because not only does it create a shared community norm, but it also provides the basis for reporting to this mobile court, for organizing pledges, and for ensuring accountability in keeping to them. Monitoring has played an important role because when commitments are made, the monitoring helps to check what is actually happening on the ground. And as I mentioned earlier, care and support for those who have experienced FGM as an important part of this overall response. The sixth and last area discussed in this paper is menstrual hygiene and health. And the slogan is the movement, the Menstrual Health Day slogan. It's time for action and no more limits. And again, a wonderful cartoon by Graham Ogilvy. Another crowded slide, I'm afraid. In terms of levels and trends, there's limited data on levels and trends within or across almost all low and middle income countries. There's a growing body of literature, though, on how menstrual stigma and inadequate social and physical environments hinder safe and dignified menstrual management. In terms of global and regional responses, the ICPD Plan of Action made no mention of this area. Attention to menstruation as public health, as a public health issue, as a social and a rights issue, began in the mid-2000s. Again, it was not part of the MDGs. Norms and standards have been developed by a number of organizations, and alliances to move the agenda forward have been formed. A notable one is the African Coalition for Menstrual Health. So this has brought together activists, NGOs, academics, service providers. And in the 2010s, there's been a slowly growing investment in research on menstruation in the school and humanitarian contexts. In terms of national and subnational responses, the water, sanitation, education, and health sectors in a small but growing number of countries have developed policies and strategies on menstrual hygiene and health. The countries are listed on the slide. The activities include free product distribution and education, but the focus is largely on products. There's a growing menstrual equity movement, which is fighting to overcome restrictions on the entry of menstruating girls and women to temples and other places of worship, to overcome taxes on sanitary products, and to address period poverty. Menstrual Hygiene Day, like the World AIDS Day in the past, has become a norm, something that is looked forward to and celebrated as a means of raising visibility and ending the silence in this area. So at the end of the ICPD era, ICPD plus 25 era, the menstrual hygiene movement still struggles to gain traction within larger ASRHR efforts. So what has helped? Reports of girls and women's experiences of shame and embarrassment and of the barriers they face in managing their periods have helped draw attention to this issue. And the growing attention to girls' needs and rights more broadly have also focused attention in this area. And the work that began in southern countries, in countries such as Tanzania and India and Egypt and elsewhere, are now fed into activities in northern countries, in the UK, in the USA, and elsewhere in the context of period poverty. What is hindered? The limited evidence on how to meet girls' needs and how to measure them has hampered progress, and there's still widespread lack of understanding and acknowledgement of the place of menstruation in issues such as early menarche being a trigger to child marriage and the effect of amenorrhea on contraceptive discontinuation. All these are areas that need to be studied, which will then help cement the place of menstrual health within the broader agenda of adolescent sexual and reproductive health and rights. So we are pleased to celebrate the work that has been done by Nepal in putting menstrual hygiene and health on the national health, development and human rights agendas. In 2005, Chowpadi, a harmful traditional practice in which girls and women are required to stay in an outhouse during their periods, was outlawed. In 2008, guidelines on the eradication of Chowpadi were published by the Ministry of Women, Children and Social Welfare, In 2017, a law criminalizing chowpatty was passed, and education and social change movements complement these efforts. Menstrual hygiene is now part of a number of policies as listed on this slide, but there are some gaps. For example, disability, and these policies have stimulated activities within these sectors, but both sectoral action is weak and coordination is weak. So while progress has been made, much more needs to be done. But Nepal clearly is a front runner in the progress that it has made. That brings me to the end of this presentation. So to wrap up, some conclusions. Point 1. Some aspects of adolescent sexual and reproductive health and rights are higher on the health and development agendas than ever before. This has been as a result of advocacy by a growing body of stakeholders, including young people themselves, by high-profile consultative processes and conferences. And all these activities have drawn attention to the demographic, public health, economic, and human rights rationale for investing in adolescent health in general and in adolescent sexual and reproductive health and rights in particular. The second point is there's a steadily growing financial investment in this area, although much of the financial investment is from external sources and remains fragmented and inadequate. Funding is there for some areas listed on this slide, but it's not there for many other areas, as we noted earlier. For example, in preventing and responding to violence against women and girls. The third point is that while there are still many gaps to be filled, there's a growing body of data and evidence on ESRH. This is fed into norms and standards at the global level and at the national level. On the slide in black, you will see a list of issues on which there's a growing body of data and evidence, and some issues on which there are gaps. Norms and standards have been developed on these issues, but some areas are not covered. And for example, contraceptive provision to unmarried adolescents. Sometimes guidelines developed by different organizations do not say the same thing. That confuses the field. And the third point is that guidelines do not often reach decision makers, and even if they do reach them, they do not feed into policies and programs always. So these are some of the issues in terms of evidence and norms and standards. My fourth point is that although implementation of ASRHR policies and programs in many countries remains weak, a small but growing number of countries have created and implemented enabling legal and policy environments and strong government programs. We've described some of these in this paper. In some areas, like child marriage prevention, progress has been made. In other areas, for example, provision of comprehensive sexuality education and safe abortion care, there are still huge restrictions. And in many places, laws defining the age of sexual consent and classifying sex before that as statutory rape requiring reporting have really contributed to worsening the situation. These laws combine with stigma and discrimination to block access to services. Non-government organizations were the first to respond to ASRHR, and they continue to play the role of service providers, innovators, advocates, and watchdogs. Over the years, national governments have developed policies and strategies and developed programs. Today, most countries have national adolescent sexual and reproductive health programs of some form, either separately or integrated within broader programs. In many places, however, NGOs and government employ ineffective interventions and deliver interventions poorly or in a piecemeal manner. In a small but growing number of countries, happily, this is beginning to change. My fifth and last conclusion is that although there's a growing body of support for addressing some aspects of adolescent sexual and reproductive health, there's ambivalence about other aspects, and there's increasingly well-financed and well-organized resistance for some areas. There's support for child marriage and ending violence against women and girls, but there's enormous resistance to promoting safe abortion and providing contraceptive information and services to unmarried adolescents. In many places, increasingly strong resistance has led to stalled programs or reversed progress. On the other hand, in some places, initiatives have learned to deal with these resistance and work around it and to overcome the resistance and to build support. Robust grassroots level movements, including those led by young people, have become active and influential in moving the agenda forward. These issues are discussed further in paper 4. To conclude, I come back to the two questions I posed at the start of this presentation. How have epidemiologic trends and political research, programmatic and social responses to ASRHR evolved in the 25 years since the ICPD? The answer to the question is progress has been made in each of the 6 areas that we've looked at, but the nature of the progress, the level of progress, the nature of the response and its trajectory have been different. And this is because of a number of factors in the research agenda, in the political environment, in the social environment, as we have discussed. So finally, what contribution did the ICPD make to this? The ICPD has contributed to the progress made on ASRHR, both because of its bold call for action 25 years ago, but also because it stimulated efforts at the global, regional and national levels that continue to this day. See, the ICPD has become a framework, a basis for discussion throughout the last 25 years. So it's not just a document, it's also been a framework for engagement, for discussion, for debate, and for action. That brings me to the end of this presentation, this long presentation on this paper, which, as I said in my introduction, has been put together by a huge body of people working together. Thank you.